So Tim, you and I see the world through slightly different lenses, although I think as I listen to your talk and know where I am, we share similar views about the importance of this legislation and what it's accomplished. And so I guess I would have a couple of questions for you. Do you see a scenario where the Republicans repeal the PPACA, or do you think this is a piece of legislation that's here to stay?
I think at this point it's here to stay. And if you look at polls, what you see is that there are an awful lot of people who don't like the Affordable Care Act. I think many of them, what they really don't like is their understanding of the Affordable Care Act rather than the Affordable Care Act itself, because when they poll people and ask them then about specific provisions of the Affordable Care Act, they say, yeah, that's great, that's a great idea, let's do that instead. But when you ask people then, do you want it repealed, a pretty significant majority say no. And frankly, we now have 7 million people with enrolled through the exchanges and another 7 million on the Medicaid expansion. So rolling that back would be a pretty big deal. Also, as long as President Obama is president, he, I think, is not going to agree to a repeal. So the question then is what kind of amendments might be acceptable to both parties. And I think there is some room for negotiations there, but unfortunately, at least until I think the next senatorial election is over, neither side is going to budge. And maybe after that, we might be able to make some changes.
Where do you think those changes might be? And I guess as a corollary question is, if you were king and could have written the legislation to your liking, what might be different?
Those are two very different questions.
Indeed they are.
I mean, one place where I think there could be some room for some pretty fast action is the employer mandate. And I've written about this, the Health Affairs, a month or so ago. The way in which the employer mandate is currently structured just doesn't work, and is creating a lot of disruption. And I think we could rewrite the law in a way that would be much less disruptive and accomplish the same goals. As far as, and so that might be one place where we could work together. The Affordable Care Act, though, was basically built on Republican proposals. Things like the individual mandate, things like using health insurance exchanges, using premium tax credits rather than a straight government program. Those are all ideas that came out of moderate Democrat and Republican circles. I think that it was a mistake to try to build a public health care system on a private insurance model. And the complexity of trying to do that is just mind-boggling. I follow all of the releases that come out of the agencies, the implementing agencies on healthcare reform, and some of the most complex parts of it we haven't even started to implement yet. But it was just never politically possible, never has been, maybe never will be politically possible in the United States to create I don't think you have to have a single payer program, but I think you have to have a public program that will fill the gaps in the employer-based system, which could eventually lead to a single payer system, because I don't know how much longer employers would offer health coverage if it was otherwise available. But I think a system like that would have made a whole lot more sense. It just wasn't politically possible. Let me ask you a question.
Certainly.
I was at a conference over the weekend of law professors, and one of the people who was on a panel had put out this idea that as we move away from fee-for-service payment and move towards more, capitated payments, bundled payments, case-based payments, that hospitals, and also as we begin to penalize readmissions in a more significant way, that hospitals might, or health care systems might find it in their interest to try to address social determinants of disease beyond strict medical issues. And you talked about providing transportation for people who couldn't otherwise get to their appointments, but could you see a situation where maybe food, special diet kinds of things would be provided for people, or, we could start to work with problems beyond strict medical problems?
So I absolutely can see that day coming. And I think one of the challenges that we as healthcare professionals have, especially doctors, is that we look at healthcare through the lens of disease. That's how we've been taught. We don't look at healthcare through the lens of wellness and prevention. Mm-hmm. And one of my learnings in this work has been that I need to take off those glasses. Mm-hmm. I need to see the world of healthcare delivery as occurring beyond bricks and mortar of clinics, emergency rooms, and hospitals. And we need to make this a community discussion where we begin to partner with, engage, and leverage community resources around exactly these issues. We need to be in schools, talking about nutrition, ideally creating incentives in the school to provide healthy diets to kids. Mm-hmm. We need to be talking about weight management when kids are in kindergarten and not when they're already obese. We need to begin to engage community resources, churches, community health centers to do this work. And so once you take off those glasses, it's a completely different world for me in terms of thinking about how to redesign the care delivery model. One more example, and then I'll let it go. We've had a fascinating discussion with a group called Kendall, which is a retirement community that enrolls people who are probably more affluent and not impoverished.
There's one right up the road from here.
Fair enough. But the learning from Kendall for me is that they have engaged community resources, their own individual residents, as caregivers, coaches. They provide that care for free because it's the right thing to do for the community. And so when you begin to think about healthcare delivery and prevention and wellness through that lens, and I was intrigued by Jean's comments last night because she's doing a lot of that work in Dorchester as well. She's engaging communities and resources around things like diet that translates into prevention. And so yes, I absolutely think that we need to expand how we think about healthcare delivery in this country.
Can the financial incentives to healthcare providers be structured in such a way that that becomes an attractive thing for providers to do as opposed to doing tests and procedures?
So I hope so. We're not there yet. And I think that we're not there yet. I'm hoping that as we move to pay for performance and as employers and payers begin to take a longer view about taking cost out of the system, that they will come to the table. But I have to say, right now in the payer space, one of our challenges as we think about taking on risk is building trust with the payers. And in fact, we want to accomplish the same thing. They're reticent to share their data with us. And frankly, healthcare has been reticent to share our data with them. So I think that we're not there yet, but I think that's where we need to get if we're going to truly transform the way we deliver care. What is your perspective on that? I mean, you look around the country. Do you see it differently?
Well, I think that healthcare providers are at so many different places right now in kind of the evolution.
Boy, we are.
Yeah, before, over the break, I shared the story of my son, my youngest son, who has a chronic disease. And we first tried the local doctors and everybody, if they were a right arm specialist, they could think maybe there's a problem with your right arm. But trying to get people, or even to get people to look at each other's records, which was not possible, was a problem. And then we went to Cleveland Clinic, and the experience was completely different in that everybody immediately had access to everybody else's notes. We saw a number of specialists, and the records were completely available. We then ended up going to Johns Hopkins for some further help, but they were immediately able to get the Cleveland Clinic records. So I think that even at the level of being basically able to provide some kind of holistic and comprehensive care. A lot of doctors, a lot of healthcare providers, a lot of hospitals aren't there yet. And then going beyond that to provide holistic care beyond medical diagnoses is yet another leap. And I don't think we have built the incentives yet for that to happen, the financial incentives.
I would agree with that.
Do you want us to answer questions for the audience or talk to each other a bit more?
Sure, but I'll tell you what I'm going to do. I'm going to take advantage of I'm going to do a couple things. I'm going to take advantage, first of all, of my being MC here, and I'm going to
being your normal reticent self.
I'm going to ask you both a question. Tim, I promised in my introduction that sometime in the question and answers, you would talk a little bit about the challenge to subsidies on the federal exchange, and I hope you will talk a little bit about that because I know you wrote about it as late as Friday, and you might have had some few thoughts about it since then. And David, I would like, it seems to me that it's a case that in a discussion of ACA, although Tim's discussion is much more nuanced and refined and informative than most of everything you hear, at least those things about Medicaid and the subsidies are talked about out there. I think not many people know the whole side that you dealt with is really addressed by the ACA. I would like to hear you say a little bit more about how you think it addressed it and why it's pushing Cleveland Clinic and other places in that direction.
On the tax credit issue, and I've spent much of the last few months of my life working on this, so I'll try to keep it brief, but it could go on for quite a while. The Affordable Care Act went through the House and Senate in 2009, 2010. The bill that really became the ACA was the Senate bill. It was because of the political environment that it began really somewhat bipartisan, but by the end of 2009 it was completely partisan. And the Democrats needed 60 votes to get anything done in the Senate. So the Senate bill passed right before Christmas. Right after Christmas, there was a special election in Massachusetts to fill Ted Kennedy's place, and it was won by Scott Brown, a Republican. At that point, the Democrats lost their supermajority in the Senate, and so the conference bill that had been anticipated between the House and Senate bill, the House had passed a somewhat different bill, never happened, and eventually the House adopted the Senate bill and it became the law. There are a number of issues, of things. I remember through the fall of 2009 talking to staffers and saying, we got a problem here, we need to fix this, and they say, don't worry, we'll fix it in conference. Well, the conference never happened. The Senate bill itself was a merger of bills that came out of the Health, Education, Labors, and Pensions Committee and the Senate Finance Committee, and then there was a manager's amendment, and then there was a Reconciliation Act. Basic to both bills were the idea of the exchange, which was going to be a marketplace for purchasing health insurance and also the place where people would get premium tax credits. The House bill provided for a national exchange. The Senate bill said the states decided to basically give the states the first option. The bill actually says each state shall establish an exchange. That's in Section 1311. In Section 1321, the statute says if a state elects not to establish an exchange, the Secretary of Health and Human Services shall establish such exchange, the required exchange it refers to. So the idea was the states will establish exchanges. If the states decide not to, the federal government will establish a fallback exchange. An exchange is defined in Section 1563 as a Section 1311 exchange. The idea was that the federal exchange would become effectively the state exchange. But there's language in Section 36B of the Internal Revenue Code which says that it's in the provisions dealing with calculating premium tax credits and dealing with coverage months for when premium tax credits are available. There's a provision that says that to qualify, a person must be enrolled in, actually it says, in through an exchange established by the state under Section 1311. And so law was passed, and several months later, somebody looking at the statute said, hey, that means only state exchanges can grant premium tax credits, not federal exchanges, because federal exchanges aren't established by the state. And initially they said it's a drafting error, but then they said, no, that's what Congress intended. They didn't intend federal exchanges to issue premium tax credits, and they came up with this elaborate fiction as to why this is true. There have now been 4 lawsuits filed, 2 by the Competitive Enterprise Institute, one in Washington and one in Washington, D.C., and one in Virginia, and then 2 more filed by the Attorneys General of Oklahoma and Indiana, claiming that federal exchanges cannot issue premium tax credits. Both district court judges that heard the case decided that that's not what the statute says. If you read the whole statute rather than putting on your blinders and looking at 4 words, you see that Congress intended, there's lots of other language in the statute that makes it clear that Congress intended that federal as well as state exchanges would issue premium tax credits, that federal exchanges effectively become state exchanges. One of those cases was appealed to the District of Columbia Circuit, where 2 of the judges of the 3-judge panel said no, federal exchanges cannot issue premium tax credits. The other was appealed to the 4th, and the 1 judge dissented. The other was appealed to the 4th Circuit, where all 3 judges said no, the federal exchanges can issue premium tax credits, and if that's not clear enough in the statute, the IRS is supposed to interpret the statute, and that's their position. The plaintiffs, the appellants in the 4th Circuit have now requested the Supreme Court to grant certiorari. The appellants, the government in the D.C. Circuit has requested the full D.C. Circuit to rehear the case. And we should know over the next few months what happens next. And I'll finish up now quickly, but were a court to hold, which I think is completely contrary to the purpose of the statute, the language of the statute, the intent of Congress, that federal exchanges cannot issue premium tax credits, it would mean that in at least 34 states, possibly more, there would be no premium tax credits. The employer mandate wouldn't apply because that's conditional on premium tax credits. The individual mandate would be greatly weakened for reasons that I won't go into. And you would effectively have 5 million people would lose their premium tax credits and lose their health insurance. You would effectively have a situation like that existed until a couple of weeks ago in the Virgin Islands or Guam, where the health reform requirements apply, but there are no premium tax credits, no employer mandate, no individual mandate, which is to say the insurance market, the non-group market, completely shut down. Nobody could buy health insurance outside of their employment. So this is an existential threat to the Affordable Care Act, and also to anyone who doesn't have insurance through their employer. You're going to be uninsured. So I'm hoping that the courts realize that Congress could not have intended to hide this little secret provision in the bill that would destroy the bill, and that the courts will uphold the IRS rule that allows federal exchanges to grant premium tax credits. But unfortunately, the courts at this point are about as highly politicized as the legislatures, and I think see themselves as little legislatures rather than courts. So we'll see where that goes, but you can tell how I think about it.
I think the same way.
Okay.
Any consolation? So I believe,
Ohio is a federal exchange state.
yes,
so,
indeed.
yeah.
So, Harlan, I believe you asked me to comment more explicitly how and why the Patient Protection and Affordable Care Act incentivizes and drives health systems to make the changes I've discussed. Is that your question? So, I would make a couple of comments about that. The Affordable Care Act sets the groundwork for the creation of so-called accountable care organizations. What are accountable care organizations? Well, an accountable care organization is a legal entity that is comprised of primary care providers who come together and agree to manage a population of patients. They can be Medicare beneficiaries, and there are more and more commercial and now Medicaid ACOs that are springing up. The charge is to improve quality and lower cost, or to bend the cost curve. And if that group of primary care providers can hit certain quality targets and certain cost targets, they share in the savings that are accrued. ACOs are springing up across the country. There are more than 300 Medicare and Medicaid CMOs, and in fact, a greater number of commercial ACOs. So suddenly, the discussion has turned to become an ACO, to manage populations, to improve quality, to lower costs. That's one. The second thing that has happened is that with the exchanges, products are coming onto the exchange that have different prices, and it's become increasingly clear to us on the provider side that many patients who go onto the exchange are choosing based upon price or affordability. Well, those products on the exchange include certain services and certain health systems, and many of them exclude higher-priced health systems like the Cleveland Clinic. And so all of a sudden, we are at risk of seeing major loss of populations of patients that we have traditionally served, because as patients choose exchanges and as employers offload their insurance to high deductible plans or to the exchanges, in the market there is the potential for major shifts in market share between different health systems. And so that, too, has really fueled the fire to improve quality and take cost out of the system. And as a downstream corollary effect, commercial payers have now taken up that mantra. And as they think about, employers and commercial players think about the offerings that they're going to make, cost and affordability are major portions of the discussion. And so that has got, all of those confluence of factors has gotten health systems in the game about competitiveness around affordability and improving quality. Does that answer your question?
Why don't you go ahead and ask the first question? And make sure you turn your mic on first. I can handle that.
Okay, great. Hi there. Thank you guys so much for talking to us. My name is Yashna, and I'm a student here at Washington & Lee, and I worked with the Camden Coalition of Healthcare Providers this summer. And a lot of my work dealt with community-based quality assessments for an ACO takeoff project. So that was really interesting. I spent a lot of my time waiting in waiting rooms with patients, sort of observing office dynamics and that kind of thing. And my question pertains more to Dr. Longworth on the quality of care side of things. So in my work, I witnessed two sort of counter opposites. I noticed that there were very efficient practices that were running, more hospital-based practices that had a really good patient flow, and people were just coming through the office with maybe like 15 minutes of wait time, but they didn't really have a consistent physician, and there was really no doctor-patient relationship that was able to be made. And then on the other side of things, I saw smaller practices where maybe 4 to 6 patients would be seen before lunch, and each patient had a great relationship with this one provider, but there was probably 1 to 2 hours of wait time involved in that process. So I was wondering, how do you, as a provider, suggest that maybe us future physicians sort of like strike that balance between keeping to an efficient schedule and being respectful of people's time and sticking to that 15-minute suggested time limit while maintaining a doctor-patient relationship that's still good?
Well, thank you for the question. You have struck to the heart of the matter about the misaligned incentives in the different payment structures that we currently face. In the fee-for-service model, there is the incentive to stay on time, to see as many as you can, to move them through the door, to move them in and out, to not perhaps address the more nuanced issues of what's going on, to address prevention issues, engagement issues. That is today, and what you've described is the reality today for many providers. In the current payment structure of fee-for-service, seeing 4 to 6 patients in a half-day session does not float the boat and is not economically viable, but does do the right thing for patients. And I think that over time, the payment system will need to catch up so that if you're in a total cost of care contract where you're paid a fixed amount, then that becomes a different discussion about how many you see. You see who needs to be seen, and you do the right thing. And so I think that you've struck at the inherent tension that all of us face today. So how do you find the balance? So I think as we try to find the balance, we are trying to build multidisciplinary teams around patients with hiring medical assistants who operate top-of-license, care coordinators who can deal with some of the planning issues, some of the psychosocial issues to give people the time that they need. But that's been an investment for us that we've made anticipating where things are going. In my own personal experience, I don't consistently run on time. But if I say to a patient, you know, the person that I saw before you had an issue and I needed to spend more time and I am here and in the moment for you, the vast majority of patients understand that type of discussion. And frankly, it's rare to have a whole clinic where they need to be 1-hour discussions. And there are ways of managing that. You know, I can't see you today, but I'm going to bring you back in a couple of days and we'll finish this discussion. But no question, there is inherent tension around misaligned incentives around payment that drive these different behaviors. Does that answer your question?
It does. Thank you so much.
Yes. Brian.
You have to let it turn on and then turn green. If it turns green, you're good.
Hi, I'm Brian from Middlebury. Thank you so much for both of your talks. They were very informative for someone that really did not know much about the law or the healthcare side of things beforehand. And my question is kind of for either of you. You mentioned that countries like the Netherlands with 16 million people are running a very effective system, spending less money, and the records are all electronic and whatnot. But I'm wondering if we look at specific states, maybe Massachusetts, for example, where I'm from and a little bit more familiar with, maybe we'd see those same efficiency ratings with a statewide system. And that's kind of the main argument I've heard from people against the ACA is that, states should be able to run it better and we're trampling on their rights, which I didn't really understand personally, but I'm just wondering, where's the limit for kind of providing inclusive healthcare and getting these people that are not in the system right now, the impoverished people, the care they need? And do you believe like a federal system with over 300 million people is actually going to work, or is there a limit and smaller groupings would be kind of creating a better system?
Well, I think what we have right now, I think that first, I think it is a good point that if you look at variation among the states as opposed to variation among countries, you see almost as great variation among some of the states as you do among various developed countries. And Massachusetts, I think, is a good example of a real leader in terms of its insured population. There are virtually no uninsured children left in Massachusetts at this point, at least not that are legally here. On the other hand, it has a very expensive system comparatively to some of the other states. I guess my concern is more, I do believe that a national system is better because I do think we just have to have a national floor. I mean, you look at some of the states now, particularly states that have had really bad health statistics to begin with and then decided to forego the Medicaid expansion. And the conditions are just abysmal and much worse than the national average. And frankly, we are one country, and I don't see the logic of allowing poor children in Mississippi or in Texas to be receiving much worse care and much less care than poor children in Massachusetts or Minnesota or some of the other progressive states. I think we certainly should allow states to innovate and to go beyond a national floor if they choose to do that. And that's permitted under the ACA. As I said, states can go above 400% of poverty, or 138% of poverty if they want to in their Medicaid programs, and some states have. and states can provide other. Vermont is talking about moving to a single-payer system. So I think states ought to be allowed to innovate, to move beyond. As of 2017, any state that wants to can apply for an innovation waiver where they would be free from the basic requirements of the Affordable Care Act, but they have to ensure that as many people get health care, they get as inexpensive health care, they get as comprehensive health care as they would have gotten under the Affordable Care Act. But I just don't see saying that if a state, I mean, I really do think it goes back to 1935 when some states wanted to keep certain parts of their population permanently disenfranchised and in poverty. And I hear the debates about Medicaid expansion nowadays. I'm not sure how far we've moved beyond that.
So I would agree with Professor Jost. I would love to see a single-payer system in this country and a unified electronic health record. I think both of those would take significant cost out of the system and would help us drive quality. As we contract with different payers, they all have slightly different quality targets that we're driving to. We cannot convince them to line up around single quality metrics with which we might all agree. The reason that that's a problem is because of all the overhead and administrative infrastructure that is required to measure, monitor, and report. We have so much administrative oversight burden that could be taken out of the system if we had single payer and unified quality metrics that we were driving to. But I just don't see the political feasibility of that, at least in my professional lifetime here.
Yeah.
And to your point around justice, for me that's an issue as well.
Yeah.
Thanks so much.
I'm Carl Malowski from Bucknell University, and that's rural central Pennsylvania. We've had a sort of big student volunteer Affordable Care Act project signing people up because no institutions in the center of Pennsylvania took the lead to educate people or provide help for signing up. And one of the things I find puzzling is that none of the hospitals have been willing or much inclined to purchase paid. And I would think that with a requirement to provide emergency care to medically indigent people, hospitals would be losing lots of money, and that getting people insured would be a moneymaker, and that they would line up. You gave statistics about how much better hospitals are doing in states that have Medicaid expansion compared to Pennsylvania, which doesn't. So I'm just wondering if you can shed some light on what's going on.
In fact, in most parts of the country, hospitals and community health centers have been sort of the driving force in signing people up. I'm kind of surprised that that's not true in central Pennsylvania. There was established under the Affordable Care Act a program called the Navigator Program, and the idea was that there would be people trained to sign people up for the Affordable Care Act. They would go out into communities, they would sign them up. And in some states, that's working out reasonably well. In the federal exchange states, including Virginia and Ohio, those programs were seriously underfunded. Also in Ohio, you had an insurance commissioner who was very hostile to the program.
Yes, we
really
did.
Undermined it.
Yes, we did.
In Virginia, we've had a better climate with that. But in addition to that, they created a category called enrollment counselors, and another one called sisters. And there are far more enrollment counselors than there are navigators nationwide. And as far as I can tell, most of the enrollment counselors are located either in hospitals or community health centers. And they have been playing a very important role. I'm glad to hear your students were doing it too, because and the other thing is agents and brokers are still could play a very important role here, have played an important role in many states. The unfortunate truth is that the enrollment system from the outset was very, very badly broken, and they managed to kind of patch things together by the end so that there's such a huge demand, we did get many people enrolled. But they never did really succeed in getting agents and brokers as fully engaged as they need to do. So I'm hoping with the open enrollment period this year and next year, They're going to be much more successful with that. The navigators are being refunded. There's going to be a lot of enrollment counselors, and hopefully the outreach will be there to get people signed up, but we have a long way to go. And this is an area where there has been no new funding voted for the Affordable Care Act since the act was passed. There was $1 billion in the original appropriation. Congress has not appropriated another penny. So it's been a matter of kind of, finding a few dollars here and a few dollars there to patch this thing together, and then saying, well, nobody's signing up. Its system isn't working. Well, you get what you pay for or don't pay for. So, although I must say also a lot of the money wasn't very well spent with some of the contractors, but we really do need more outreach, and I think that is an important role that students can play. In the Valley here, Blue Ridge Legal Services the legal services in Virginia is the Navigator. Blue Ridge Legal Services is for this area, but I'm sure they could use a lot of help.
Nancy Shepard from Boston or Stowe, Massachusetts. And Dr. Longworth, first of all, thank you for all that you had to say about the value-based model. And I'm sure maybe some other people, in addition to myself, noticed that both you and Jean Dubois last night talked about the value of teams. I liked the fact that came through. I wonder if you have a sense of what the costs will be in the value-based model, and if you could say something about that.
So do I have a sense of what the cost will be? Well, it has to be lower because it's out of control. We are, right now at the Cleveland Clinic, we are a $6.5 billion enterprise. We are trying to take $300 million this year out of our fixed costs. We're in the midst of a budget cycle. I don't know, I think we have to become competitive with the other countries in the developed world in terms of the data that I showed you, and that suggests that we have to take at least, have our costs. I don't know, I'm concerned about the feasibility of that, but I think the costs have to be dramatically lower. Care has to be affordable for people. I haven't answered your question quantitatively.
Continue to watch and think.
One thing I don't know that everybody knows this, but healthcare cost growth has declined dramatically over in the last 3 or 4 years.
It's flattened.
It's flattened. The rate of growth in healthcare costs has been the lowest that it's been probably in our lifetime.
Yes, I agree with that.
There are a lot of reasons for that, some of which aren't too pretty, like we've been going through a recession where people have had less money to spend. But it also looks like there are some organizational factors that are starting to, as they say, bend the curve. So there is some hope. They just said that Medicare is now safe through 2030, whereas a few years ago it wasn't going to last till now. So I think that we're starting to, but I mean, the whole idea of value is that it's not just quality, it's also cost, which is your whole point.
Yes.
So hopefully we are starting to move in that direction.
I think one of the challenges we've seen, though, as we've seen more movement of plans from employers to their employees and the exchanges, our volumes have softened for basic preventive services.
Yeah.
And so we worry that people are not seeking the care that they need today to prevent the trouble that's going to happen down the line. So I, too, am reassured by the flattening of that curve, but I think that it's a complicated discussion for me about why that's happening.
Yeah, I agree.
My name is Zachary Arnold. I'm from Washington and Lee University, and I worked at Frontline Service in Cleveland for my internship.
Thank you.
And my question for both of you is, as you see the focus switch to more holistic care and preventative care, how do you see hospitals adjusting to that? Do you see them maybe financing services like Frontline Service and allowing them to do more with their services to help coordinate the housing or food or whatever deficiencies that are adding to the healthcare problems? Or how do you see the future of preventative care moving forward?
Well, I think that once the economic incentives are in place to keep people out of hospitals, the tide will change and quickly change. The heretofore, in the fee-for-service world, hospitals have been profit centers. That's what drives healthcare systems, is the profitability of hospital admissions and readmissions, and providing testing and treatment that may or may not be appropriate. If you go to a world of value where it's total cost of care and it's about doing the appropriate thing and keeping people out of emergency rooms and hospitals, some hospitals, in fact, have a big problem. A place like the Cleveland Clinic, a huge physical plant with enormous fixed infrastructure costs. The goal regionally for us is to keep people out of those beds, keep them well. Because that is what the payment methodologies will drive us to do. And so as we think about the strategy at the Cleveland Clinic, we have two parallel strategies. One is that we want to begin to build programs around chronic disease management and wellness and prevention for the regional population that we serve. But at the same time, we need to differentiate ourselves to provide very high quality, affordable, high-end quaternary care that most other hospitals won't be able to provide, so that we can compete for that business and contract with employers, with payers, with other ACOs. And so it is a complicated discussion, to the point you make.
My name is Morgan. I'm from Center College, and I was at Lift Philadelphia this summer. We keep talking, or you all continue to talk about a value-based system, but it seems to be only applying to people who are already American citizens. And I believe it was mentioned in another healthcare talk that we did a few days ago that our undocumented immigrant population would be around 25%, I think she said 1/4 of the people who would be in desperate need of healthcare. So how do you think they will fit into our either current healthcare system or this value-based system that you are describing?
Well, as the Affordable Care Act passed through Congress, you probably remember the moment when President Obama said that illegal immigrants would not be covered, and somebody yelled out at him, "You liar." This was a very important political point, that we exclude undocumented aliens from this system altogether, and it effectively does that. And that's a serious problem, particularly in some parts of the country where, frankly, where I live in Harrisonburg, I think the economy depends on undocumented workers. That's who's processing the poultry that we grow in Rockingham County. But they do have access to community health centers. Community health centers are not supposed to ask about documentation. They can enroll their children, and if the child is a U.S. citizen, the enrollment process is not supposed to ask about citizenship status. They can still get emergency care in emergencies, and hospitals can get reimbursed from that for Medicaid, even though the person doesn't qualify for Medicaid. But it's a major problem, but of course it's part of a much bigger problem, which is how do we deal with our immigrant population in this country. And hopefully when that problem is addressed, this problem can be addressed too, but I don't see it being addressed independently.
Hi, my name is Megan. I'm from John Carroll University in Cleveland. I'm just wondering, given the shortage of primary care physicians and the fact that the patient population will be expanding as more people have access to insurance and care, what's being done to address that shortage, or what should be done?
So the question is, how can we expand the primary care base? Well, it is an important consideration. I can tell you that those of us doing this work are trying to, first, improve compensation. Second, improve work-life balance. 3, move to top-of-license care so that primary care physicians are spending time doing the doctoring work and not doing the paperwork that others can do. The whole concept of redesigning the care delivery model so that there's pre-visit planning done by a medical assistant who in fact identifies gaps in care, and you have a care coordinator to support you in the work. That's a fundamental change in the way primary care docs will practice, and we've got some data that they're much more satisfied in that model. I think that there are some places around the country where, to incentivize that work, there are loan forgiveness programs in place in order to try to hire people or get them into the specialty. The final challenge that I see is that in many medical schools across this country, there is a hidden curriculum. Those schools are so subspecialty driven, and the path of honor that kids see coming in the front door is that you become a specialist because you're a higher form of life than being a primary care physician. And we've got to work to really reshape the way we as medical educators frame the discussion. Does that answer your question? Great.
Here, this one, thank you.
All right, my name is Jillian. I'm from Bucknell University. My question pertains to the value-based system you talked about earlier as well. I was just wondering, you mentioned that cost would be determined based on efficiency and quality of care. I was wondering if you could talk a little bit more about that, and then if there is a variability in cost, potential costs, how would that look with insurance coverage?
So I think that the cost of care or the prices charged is already transparent. And if you go up to a site called Castlight, they are making their money by posting what the charges will be to get certain services, a primary care visit, an urgent care visit, an ER visit at different sites. They are posting what it costs for a CT scan at the Cleveland Clinic versus an independent imaging center in Cleveland. That's out there to the public. More and more people are going to those sites, and there is great variability in the charges. We're high-charge providers. Boy, that's a wake-up call for us. We're in the process of dramatically reducing our charges for laboratory services and high-end imaging studies. And so with that transparency, it will challenge health systems to really make care more affordable.
Hi, I'm Kiki Spezio. I go to Washington and Lee University as well. And I was wondering if you could both speak to the implications that you foresee coming out of the Hobby Lobby ruling.
Well, I frankly don't think that the implications are that great. I think that, what the Hobby Lobby case held was that a for-profit employer did not need to provide contraceptive services if they had a religious objection to it. And in fact, it was specific contraceptive services. It was Plan B, Ella, and IUDs. I just think that there are very few for-profit corporations who would take that position. I think most for-profit corporations, certainly publicly held, are in it for profit, not for their religious beliefs. So I think that the immediate implications of the immediate decision are probably pretty limited. More broadly, it will no doubt encourage people who have particular religious beliefs that they hold very deeply to raise those when they find that laws of general applicability would seem to adversely affect them. But for example, there are religious groups who object to providing health care at all. There's Jehovah's Witnesses have problems with transfusions. There aren't any lawsuits out there like that. I think it's a fairly specific and fairly limited group of organizations that see this as an issue.
I see it that way as well.
It's hard for me to imagine having three people more knowledgeable about their subject and about a subject that's very important to us than Gene Dubois and Tim Jost and David Longworth. And I remembered his name. And so thank you guys, all of you, for being here with us, and we appreciate it. The best to you. Those of you who will be meeting with Rebecca Todd Peters regarding pedagogy and making plans for pedagogy and working with, in a follow-up on the Millsaps conference that's going to meet in the left-hand corner at the back. And everybody who can, who's a teacher of poverty at one of our institutions should try to, who can stay, should try to get involved in that meeting. Thank you all very much. We'll stay in touch a whole lot, okay? Thank you.
Good to see you, and I'll see you in the fall.